Yes.
So did you have anything on your mind that you wanted to share?
Well, as it happens, I have a patient who has a snapping hip, and although it is not painful, it is quite significant. And he was asking me about it, and I was considering the data on snapping hips and how to treat them practically. Many times I see that um, there is an emphasis on strengthening the hip flexors to cure snapping hip, but I
One
think,
thing, let me ask, just for context, like how old is this person?
oh, this gentleman is in his maybe he's in his late 30s, early 40s, and he's
Okay,
very active, and
very,
he's
and you said, I think you said it, but not asymptomatic hip. Just the
no,
fact
it
that
is
it's
disturbing him, but it is not yet painful.
okay.
But it is significant. I mean, you can hear it and you can palpate it, and it
Yeah.
is one of those ex. It is one of those external to the hip, but internal to the pelvis. So it is a true snapping hip of the iliopsoas complex, which there is a video, an ultrasound video by Levine, who has shown the slippage of the psoas tendon
Hmm.
um, off the iliacus muscle belly on the extension of the hip, from flexion to
Wow.
extension. So this is a fascinating video and finally confirms the moment that the interposed iliacus muscle belly, medial portion of the iliacus, slides away and the psoas snaps back onto the superior
It
border.
actually is a mechanical snapping of
It
the
is an
thing over.
absolutely
Yeah.
that it is, yes. I mean, you
It's the
can
bone
have
going
once
right
the
back into place. It cracks and we put it back in
that's right.
place.
So, there are not true snapping syndromes which happen within the articular joint itself. It could be something to do with cartilage, the labrum, etc., etc. But this is and then of course you can have snapping hip of the IT band, the glute max, TFL complex over the trochanter, and then you can have this one along the superior ramus of the pubis. So the idea then is to really find out. Again, you have a failure to perform a movement without some kind of perception of pathology. So the moving or the hip flexion causes something that is considered aberrant. So then that is the failure to perform. So the first thing then again was to collect data around this failure. You had to find out what were the components of the snapping hip uh, presentation. And sometimes that involves looking at the range of motion. Is the hip flexor itself tight? Is it hypertonic? Is the cause of this tightness and hypertonicity local to the hip flexor complex? Or is it being caused or driven by something with the lumbar spine? Or was there an accident that caused the muscle to become hypertonic in itself? So these are really the questions that start to pop up. Is there something else? For example, if you have weakness in other flexors along that chain, for example, into the leg or so, the psoas might start helping out and then
Sure.
becomes a hypertonic, shortened, you get a contracture and it starts to snap. or you're sitting for longer periods than you were before, and therefore you're not stretching yourself out. You're using the psoas as a stabilizer for long periods, especially, for example, if you're leaning back in a chair, but you have to be forward to work on a computer. That can turn on the hip flexors as stabilizers for long periods of time. So the question was then, what was driving this? So you have to rule out and treat anything that might be driving the hypertonicity or the contracture of the muscle or the weakness. So the weakness may cause it to become hypertonic and tight. So having you look at that and you start to treat these, you gather the data, the baseline data, which is the physiological baseline, and then you check the lumbar spine against.
Which, I mean, just for me to just to say it for everyone, but when we talk about the physiological baseline, in addition to just gathering range of motion of lumbar spine, but it's also range of motion of the hip complex, or regional muscle testing of the lower
That's
extremity,
right.
palpatory signs, whether it's a nociceptive kind of screen or just palpation for tender points of the entire lower quarter, not just simply the local region of the hip itself.
That's right. Because you need to have enough data to be able to detect a change, any subtle change from the provocation of the lumbar spine or from the foot, etc. You really do not know what is driving this change in the hip flexor complex.
Right.
It could even be something like chronic gluteal inhibition due to something. You stub your toe, you stop using your glute max, the hip flexors dominate neurologically the hip, and slowly you start to get a snapping hip. So it could be any of these kind of things, or even another patient who had torn his plantar fascia, then started to have some pain around the TFL, and treating the TFL alone is not going to be useful because the cause is the foot. And unless you can restore pain-free function of the foot and weight bearing, you are going to have some kind of chain collapse and imbalance of the muscles around the proximal joints.
It is
So
funny you sorry to cut you off. It is funny
no.
you describing those scenarios because you said my patient comes in, he's got snapping hip, and then you start to describe what can be causing snapping hip, whether it's gluteal inhibition or chronic overuse, hypertonicity, shortness. And I know that you're not necessarily, that's not ultimately how you're thinking about and treating it, but that's kind of the standard way to think about it and treat it, which would be, okay, so you have a snapping hip. Well, maybe it's tight. Let me look and see if it's tight. Okay, well, I'll stretch it. Let me palpate it. It hurts. Well, let me stick a dry needle in it. Or it's weak. Okay, well, let me strengthen your hip. And none of that. Even if you were to be able to make that immediate change of, I rubbed it. It was painful. I stick the dry needle in it. I rub it again. It's not painful. That doesn't tell you anything. Doesn't tell you why it was painful. Doesn't tell you if that dry needling was truly effective. And similarly, you can't go from the. I mean, it's as simple as you can't go from the presenting symptom and try to work your way back. You can collect a bunch of information about the symptom, but then, like you said, once you have all the information, now you start provoking the most proximal structure, the lumbar spine.
Yes.
And
Yes.
then you see how the provocation makes global changes. And now you have a rational way, an effective way to actually go about getting rid of things that don't really need to be overtly treated, and honing in on what the actual true cause of this syndrome or the symptom is that's presenting. So
That's
I just
right.
wanted to say, because I mean, that's what my mind thought of. You started to say those things. I was like, okay, yeah, I would check the length, and then I would palpate it, but then it starts to lead you down the rabbit hole of then I would treat that thing, and it's no. You
No.
don't want to treat that thing right then and there.
Not
You
until,
have to revert back to the to our framework of. If you enjoyed this conversation and want to hear more like it, then please like this video and subscribe to our channel. You can also stay up to date on our latest seminars on our social media pages on Instagram and Facebook at IMTR Seminars.